Okay, so I'd like to leave time for questions, and this is going to be uploaded for everyone to use and download as you wish. But basically, when you're setting up a multidisciplinary pain center, it's important to identify your colleagues in respective other professions and to take the time to have a conversation with them about how they like to approach these patients, how they like the patients taken in. And a centralized intake is what we've found to be most useful, having one person, or we have had a nurse navigator in Albany, and we have a different system in Boston, but having one intake on these complex patients where the records are gathered and the story is taken in a comprehensive fashion with patient-reported, validated outcome measures, and then we can follow them over time. So this document is the one that will be available through the ICS, and it is, in the first page, what we do is show the symptoms that the patient's having, and they just because they have pain doesn't mean they don't have prolapse, for example. And then on the next page, we look for the comorbid diagnoses that will immediately make us think this is a complex pelvic pain patient and should be evaluated for small fiber polyneuropathy off the bat in the beginning. And this is reverberating through the other lectures. We all still look at this a little bit differently, but the ideas are starting to come together. And then the history, what have the patients tried before? Because that really maps out for you what you're going to want to try next. So have they tried medications to calm the bladder? Have there been medications that focus on the bladder outlet? Did they help? Should we start thinking about primary bladder neck obstruction in a female? What bladder pain medications have they tried? What bladder management do they use? Do they self-catheterize? Have they had chronic urinary tract infections? What sorts of vaginal and vulvar treatments have they experienced? Have they tried vaginal estrogen? Pretty simple manipulation. What kind of penile pain interventions have they had? What sort of bowel interventions? General pain medications? Have general pain medications or muscle relaxants helped them? And what surgeries have they had? What surgeries might have initiated the problem? What surgeries have been used to help the problem? Did they help? And procedures and treatments: acupuncture, massage, PTNS, TENS units, pelvic floor physical therapy, different types of pelvic floor physical therapy, getting a little more information than the average urologist will pick up. And then what testing have they had done? Counseling and other psychological therapies. Having this on the list normalizes those therapies for the patients as they project what may be offered to them in the future. And what testing has been completed in the past? What do you need to look for in terms of records? And then what types of providers have they seen? Do they already have a rheumatologist or a neurologist, a gynecologist? And if not, you can keep track of the direction that they need to move. And lastly, current working diagnoses. Now, I know Jeanette Potts prefers a one-page timeline of everything the patient's tried. It's a little bit more concise, and we all have our own approach to patients. But for the complex patients, if this is a useful tool to you, please feel free to use it. Thank you.
We're at the end of the scheduled program. There's microphones here and here, and if anyone has questions, and if you have a question for Elise, you should ask it right away because she's going to have to run out where the rest of us could stay into lunch if anyone has questions. Well, I'd like to start with Elise. Oh, okay.
Hi, I'm Mitch K. from Scottsdale, and I actually knew Jeanette back in the late 80s at Cleveland Clinic before she went on her journey. I'm in private practice, and we get to do some unique things, and I've been actually using some stem cell-based therapies off-label that aren't covered, and have found people with things such as that have been classified as restless leg syndrome. I've been doing a lot of pudendal nerve blocks and things like that, and have seen a moderate amount of success. So I was wondering if you have any experience, because I've harvested people's bone marrow, injected into areas, or I'll use some of the off-the-shelf products that are used in a non-FDA approved approach and have seen some reasonable success for things such as this.
No, I'm sorry to say that we don't have experience with that, but we're happy to learn. And I'm curious if Dr. Day or Dr. Argoff could have noticed any overlap with, some of these genetic issues. Is there a role? I mean, is there any connection when you're giving these, new cells? These you're doing regenerative type of therapy. Would that apply to your?
So I think you raise a very intriguing observation. I think the field of regenerative medicine in general is fraught with a lack of well-done studies. Not every study it has to be randomized, controlled in a traditional way to be well done. But even observational studies haven't been particularly well done in terms of patient population. I think that what would I be interested? I think there's, to Dr. Potts's point, there's a lot in a stem cell that could help a person's overall. Stem cells are being used in many different chronic pain states. What would be of great value, I think, is to have a study that characterized patients really in a standardized way, in ways that have been discussed today. And so you could look at standardized outcomes and you could get a sense of where and for whom it's the right treatment. I think everyone has, including basic scientists at the Cleveland Clinic, where both of you evidently have been from, are studying this actively. But I think we have a lack of methodologically disciplined studies that have been completed, and I would just urge those of you who are doing this work to think about that, because I think there's promise because of what we know about stem cells.
We had a lot of mention in the talks today about overlapping conditions, and so I was going to ask each of the panelists how often you find someone and actually find one condition and treat that and everything gets better.
It's rare. I mean, every once in a while you get that big hole-in-one where you have a distal ureteric stone and the patient goes to the operating room and they're better. But even those patients, after living with pain for 3 months, you've got the reactive pelvic floor disorder, and so it's important to recognize that it's almost never just one thing in the pelvis.
I would say, it could be my lack of experience, but at least so it could be a bias, but I thought it was a little easier to get the hole-in-one when I first started, because, I knew that I was going to be better than anyone else getting another, yet the 12th course of ciprofloxacin. So it did make the number a little bit higher. But I was going to also mention and ask, I didn't put it in my talk because of the time, but I often get a genogram on my patients. It's something I kind of resurrected. It's something I resurrected from my family medicine past. Now that I'm in private practice, I have time to do a genogram. And we try to notice if there are other things that, like the neuroplasticity of childhood and family dynamics and things like that that could predispose. But now after listening to both of your lectures, I'm feeling like, well, maybe it is inheritable and it has less to do with nurture and more to do with nature. I was wondering if you could comment on that.
How many people in this room have mother-daughter pain patients or father-son pain patients?
I just wanted to mention, just to go back to my question, I have seen, though, patients that do have one thing. I mean, we've had a patient this year that came in to see Dr. Potts with more than a year of chronic testicular pain that left the office pain-free after identifying a quadratus lumborum trigger point that had never been looked for. People say chronic pelvic pain, it must be a pelvic muscle problem, pelvic floor problem. And here, the trigger point in the referred pain area was there, and that could be treated in the office and not necessarily cured but left the office pain-free will come back and have stretching and additional needling if necessary. So I don't think we should lay too much crepe. We should always aim for that we can get people better and hope that we find things like that. I also wanted to, go ahead.
I have a question. Of the patients who see you too, what percent of your pelvic pain patients are eventually at least 50% better after meeting you?
I would say over half of them even just meeting us. I mean, you know, I have to be honest with you, sometimes these trials, the clinical trials I was reviewing for a talk tomorrow, I noticed that, like, I was involved in one of the trials, and I think I ruined the study. I mean, there's so many psychotropic drug studies that show that if you, if a practitioner is very involved and engaged, even the placebo improves. So a very smart person told me once that I probably shouldn't be involved in research because I'm too clinically passionate, you know, so.
I just wanted to add to the question you had earlier. We don't cure. I didn't mean to be nihilistic with that slide earlier, but one emerging treatment that we find very useful, but we also are fortunate to have the facilities to administer this regularly, is the role of intravenous lidocaine. Mm-hmm. So lidocaine, the anesthetic, it's a sodium channel blocker. Intravenous, and there are many protocols that have been published on how to safely do this, and we regularly administer to a large group. On any given day, between 5 and 10 of our patients are receiving intravenous lidocaine over multiple hours, once a week, once every other week, once a month. And that on its own allows people to function at much higher levels than any medicine they've ever gotten. And so we, there's a lot going on in the neuropathic pain world that is focused on sodium channel blockade. Certainly lidocaine's a more general sodium channel blocker, but IV lidocaine's been there are a couple of reviews that are about to be published, so it's something to think about.
I know my colleagues at Stanford, when I was there, did use a lot of IV lidocaine, but it does require blood level monitoring, right?
Other colleagues, in fact, the person who I put up there, Misha Bachgonia, the gabapentin study, he did a dose-finding study with IV lidocaine that's also been published, and talking about Sean Mackey and people like that, mm-hmm. They may be doing, because Sean Mackey is a brilliant guy who's very analytical, mm-hmm. But you don't have to do lidocaine levels during the procedure based upon other work that's been done.
So Dr. Argoff, so I have a patient that I think has Ehlers-Danlos, and he's had like a 5-year history of these migratory pain problems that don't go away. Can you share with me like an algorithm that you would go through? Like I would do a skin biopsy, I would send it to your lab, and then what would I do?
So it's not, so Dr. Loria, who, if any of you are Italian researchers, he's in Milan, and he's also been involved in the development of this new treatment, but he was the first, his group, I believe, was the first to publish the association of EDS and small fiber neuropathy. And I gave you a whole list of blood tests to consider. We do a very disciplined evaluation of each person, because we don't want to put all our eggs in one basket, make it seem that it's all EDS related, treat the treatable. And then we don't necessarily, I also briefly went past some recommendations from International Association for the Study of Pain on treatment of neuropathic pain, and I went by it quickly for several reasons. None of them have been specifically approved for neuropathic pain associated with small fiber neuropathy. And second, even the best studies, as in the gabapentin study, leave a lot of people still in pain. So we generally see people with EDS and small fiber after they've been miserable for years, as you just described. 5 years is a long time. And so we might use things like IV lidocaine, or even, if we can, IVIG. And in some instances, we've used plasma exchange, plasmapheresis, which has been shown to be helpful in small fiber neuropathy. And the interest of regenerative medicine, it's there. We just need to do the studies. So I hopefully I was very positive and upbeat about it, but there's some, additional work that probably has to be done. I'm sure you wouldn't disagree with that. And so there are a lot of emerging ways. Plus, there are several. I've had the same people complain to me about being involved in clinical trials, by the way, because I'm too passionate about stuff. But there are several clinical trials that are being done with new entities for small fiber neuropathy specifically. So hopefully what would happen is all of us would work together and we'd find that people, if it holds up internationally, that let's say 50 to 70% of people with complex pelvic pain really do have small fiber neuropathy. It's not only in our group, which I don't think it is, but let's say it really held up in studies, then maybe we should be developing algorithms that are integrative as well. And we're treating people towards a neuropathic quality of pain as well.
I was wondering, since the small fiber was like like getting hit by a wave to absorb all the information, if you could say, where are we right now? Like if I had $15 million to give you to do, the next thing to learn more about the small fiber neuropathy and pelvic pain, where would you spend it? What's the big question you'd like to know now?
So actually, it would involve maybe more than that, because I think it would be...
darn, I'm tapped out.
Well, you should have thought about that. But anyway, no, I think I want to be consistent with what I said earlier. I think if I have $15 million, I would really want to characterize the input from the periphery into the central nervous system and characterize people with complex pelvic pain in a very an enhanced fashion. And so that would also mean getting all these biomarkers and immune-mediated biomarkers and things like that. However, I also think the central nervous system is very important. And I think work done by Irene Tracy in England and others on looking at functional imaging and pain, and Sean Mackey and others, if we don't take into account that the brain may be the upset organ to begin with as well. And so I'd like more money to look at the brain as well.
Darn, I can't help you.
But I think it's frustrating. It's exhilarating and frustrating. And so I've never spoken at a urological meeting before, and I hope, this isn't the last time, because I think we need to integrate. But it's frustrating to hear. So Bob Maldwin, I used to work at the sister institution, North Shore, which is in New York City. And he had a patient that moved to upstate New York that I saw. And he had been for years told he had interstitial cystitis and such. And we opened up Dr. Maldwin's eyes to small fiber neuropathy because we biopsied this gentleman and it was abnormal. And we were able to treat him in a different way. And that improved his quality of life. So I think we really need to move in that direction.
I'm sure that some people need to leave. I'd like to remind you to please fill out the evaluations. It really helps. And Elise is head of the education committee, and she'll track you down if you don't fill it out. So please fill out the evaluation. And we can stay and take questions as long as people are willing to and have any more questions.
Thank you for coming.
Yeah.